Welcome to Clinical Unfiltered with me, Dr. Sasha. And we're just getting unfiltered with me. Last episode, we had talked about using the PASS principles or a concept that would help you kind of optimize your bone regeneration or soft tissue regeneration concepts. And I want to expand on that. I feel like a lot of you responded well to it, liked it, and a lot of you are trying to regenerate bone out there. So I wanted to expand on that, and I wanted to enter a realm of bone regeneration that is a little bit more advanced, just a little bit, honestly, because I feel like there's techniques that I always tell doctors there's like a way to do it that's good for 90% of sockets. And then there's like 10% of sockets that maybe need extra help, or 10% of grafting scenarios that need a little extra help. And the main technique that needs to be added in those scenarios is some form of flap release, like extending how big your flap's got to stretch to close, and some way of stabilizing the graft that's beyond normal, beyond just kind of opening a flap, sticking biomaterials, and squishing the flap closed again. There's something else that needs to be done. So what I'm going to describe probably fills in for the other 8%. Then there's like 2% of scenarios that need a lot of extra help, and I'll gladly do an episode about that, but I want to hit this extra 8% and focus on those two techniques, which we refer to as a periosteal release incision, and that's just a fancy way of saying we're going to extend how much mobilization we get of your flap so that you can close over a bunch of graft material you just added. And I'll touch on that in a second again. And then the other concept is periosteal stabilizing sutures. So that's suturing or sling sutures to kind of stabilize your graft. So adding those two concepts to your augmentation armamentarium is going to expand the number of cases you can do. So I really want you to kind of like zone in on these two topics. So, of course, I've got my PowerPoints, so I'm going to open them up. This is a topic I do a lot of lecturing on, and I love teaching this specific style of grafting because it's not that much harder than your other techniques, and it does add a little extra surgical complexity, but not a lot. So I feel like it's the next step up once you've been doing kind of standard socket grafts. So the reason we do it, the reason we need these extra techniques, it's often in scenarios where the bone graft is just not stable. So you have an unstable graft. And if you've listened to my past principles, you know stability is one of those S's. And if you don't have that down, your graft's just going to shift. And I always tell people a little trick that I do sometimes to check the stability of the graft is I watch the blood supply in an area I'm trying to graft, like a socket or a ridge. So what I'm showing right now is a ridge. And if you can imagine the blood just pooling in this like sloped buccal defect, the blood's just going to slide right out. It's going to look bone dry the whole time. Unless it starts pouring with blood, but that's still not stable. So if I was to put bone in here, it would just slide out like Tony Hawk on a skateboard. It would just like swoop, go right out. So you got to do something. You got to do something to stabilize your graft here. And also, if you've opened up this site and the gum tissues had collapsed to match the bone collapse here, and you start adding a bunch of extra crap here, bone graft, membrane, and then try to close the gum tissue over it, A, you're not going to get it closed. And B, in your attempts to close it, you're going to create a lot, like a chokingly amount of tension in the tissues. And you're going to choke the blood supply, or angiogenesis, according to my past principles. If you really haven't listened to that episode, go back and listen to it. You're going to cause necrosis of your flap, and you're going to just make it hard for the graft to survive. And so you're going to die off tissue. And I see this happen a lot on new doctors doing ridge augmentations. They open up, they slap biomaterials. They didn't release the flap to get it to close more. And they start choking everything off. Their tissue dies back. Their graft runs away. And they have bad results, and they blame it on the graft. It's more about the technique in these kind of scenarios. So really understanding how to advance this flap and then how to secure your graft are those two next steps you really need to kind of lock in. So in this scenario, obviously we have to do something to stabilize this graft. And if you don't, one of the other things is beyond just losing the past principles and losing your graft, loose particulate or loose graft material within the tissues is a huge source of inflammation and postoperative infection. So not only are you losing dimension, even if things heal kind of good, you're increasing the chances that things don't heal well. So you got to stabilize it. So again, the two techniques I'm going to talk about, flap advancement and stabilizing sutures. And I'm not going to go into tacks so much right now because tacking and screwing and all those other components I would consider those a little bit more advanced. The next step beyond. And I'll touch on those later. So flap advancement. I'll tell you, it's so almost confusing to describe flap advancement without seeing it. So I will tell you, the concept of flap advancement, as much as I'm going to try to visually dissect this for you, you need to get to a course to really get a good feel for it. A great place to start are pig jaw courses. Pig jaws are probably the best simulant to experience a flap advancement. You get to feel tissue, you get to see the periosteum, and you get to see it get cut. So what you're doing when you're doing a periosteal releasing incision to advance the flap is you are cutting into periosteum. And periosteum is this thin layer of tissue that is protecting the connective tissue underneath. So you have epithelium on the outside of your flap. Then you've got tissue or connective tissue in the middle. And then on the bone side, you have periosteum. It's kind of like the epithelium, and not really as thick as epithelium, but it's a thin layer of tissue separate from your connective tissue. And you can dissect this layer, this small layer, with just the thinnest sharp blade. And so what I'm showing you in this top middle picture is like the inside of a flap, where the periosteum is nice and intact. And then this picture to the bottom left, just a little bit more to the bottom left, there's a small cut in that periosteum. And it almost separates the flap into like a top layer and a bottom layer. The top layer is starting to mobilize a little bit more, but the bottom layer is still kind of attached more to the bone because there's still some periosteum attached. Now some of it has been flapped off, but the bottom edge of it is still attached. And that is an anchoring point. That's where we'll actually grab with the periosteal sutures or sling sutures or stabilizing sutures. All synonymous there. Once you make that sharp dissection, you almost want to go in and open it up more. But you don't want to keep cutting with a sharp instrument into that flap because then you're starting to cut connective tissue, possibly muscle sometime, depending on where you are. If you're in the cheek, there's a lot of muscles coming into that point. So if you keep sticking your instrument and scraping with a sharp instrument, you're going to cut into the muscle. And what happens there is you're going to cause a lot of swelling and discomfort. I always tell patients when we're doing this kind of flap advancement, when I'm doing this kind of bone grafting, it's different than just filling a socket. And I tell patients, I'm trying to bring back tissue you have lost. And in that process, I got to stretch sometimes muscle to do that. And I ask the patients, I'm like, have you ever pulled a muscle before? Have you ever torn a muscle, pulled anything? What happens? It bruises and swells. Uncomfortable. If you tear a hamstring or pull a hamstring muscle, you're tearing it, basically, same thing. And it's hard, it swells up, it's hard to walk. Now imagine I did that to your cheek muscles. That becomes and that's something you can't rest. You can rest your leg, but you can't rest your ability to talk, chew. All that gets involved with those muscles that you're dissecting into. And that's why they're feeling the discomfort. And that description of that muscle pull or tear discomfort, that achiness, that like if they use their cheeks or if they're talking or eating a lot, why it gets more sore after a procedure like this, it helps the patient understand what's happening to them afterwards. Because if they've had a socket graft and you do this and tell them it's going to be exactly the same, they're going to be so confused and call you in a worry as to why it's not feeling the same and why it feels so much worse. It is a little bit more uncomfortable to experience this as a patient. So that's why instead of continuously sharp dissecting into the flap, once you've cut just that thin periosteum, you take like a blunt instrument. I use hemostats Sometimes I use like a very blunt periosteal elevator. I've seen people use their pinky, obviously gloved, into that dissected area and do what we call blunt dissection. And it's blunt because you're not cutting deeper, you're more just pushing the periosteum away from each other. You're not really cutting into the tissues deeper, you're just making that periosteal layer, the one from the bottom and from the top, separate away from each other further. And you can do that. You can almost keep peeling away the periosteum from the connective tissue. And that allows the flap to keep stretching. That's where you get most of your release. If you just cut and then pull, you barely get any release. The blunt dissection that happens afterwards is so critical to the process. So the blunt dissection will actually get you to move the tissues much farther. But again, if you're doing this process with your patients, you really need to take that moment to explain to your patients that this is going to be a much more uncomfortable process. And I believe I have a video of it happening here on a pig jaw. So if you want to follow through, I'm going to walk you through the pig jaw video. So I've dropped a vertical incision. And when you're doing periosteal release incisions, you need to drop a vertical somewhere to get better access. I mean, could you do it with a I'll pause the video. Could you do it with a very big envelope flap? You could, but you need to visualize the periosteum. And what I was showing in this video is that when you're cutting the inside of the flap, you got to be very cognizant of where that mucogingival junction is. The mucogingival junction, I'm going to take you back just a pinch further in this video because I kind of pointed out. It's where the keratinized tissue stops. Here we go, here. Where the keratinized tissue stops and the mucosal tissue starts on the outside of the flap. If you're not aware of where that line is and you're going on the inside of the flap and cutting, you might accidentally cut through and cut off the keratinized tissue because you need to split the periosteum deeper than that mucogingival junction. Everyone asks me for a number. They're like, how many millimeters do you go deep? I'm like, are you about to actually stick a probe in there and keep flipping the flap on the inside, outside looking? It's very hard to do that. I never do that. I basically just kind of get a guesstimate of where that junction is. And if you really want a number, here it is. Probably maybe 5-ish millimeters away from that line. It really does depend on the anatomy and the location. So if you're on the lower jaw, the vestibule is pretty high, and your nerve might be very close to the area. So your mental foramen might be close. So you don't want to go too deep. You don't want to go so down into the deep depths of that flap where you're going to start cutting the mental nerve. And often when you're doing it near the mental nerve, I often recommend visualizing the canal. And if you've never done that before, I'll tell you, it's less scary than it seems. But a cone beam does help in these scenarios to get a rough idea of where that nerve's going to be. So you don't just aimlessly open the flap internally. You can lightly find the mental foramen and then start to dissect sharply so that you can dissect away from the mental foramen. But again, you got to be above the foramen, but below the keratinized tissue line, that mucogingival junction. So you got to be cognizant of that. On the upper jaw, often you don't have that kind of limitation of the nerve canal, and the ridge, the extent of how far you need to go can be deeper. And often it's much deeper on the upper compared to the lower. So you're where you're making that periosteal release incision can be much more, you can go a lot further up and be, further up, I mean deeper into the flap, and be safer. So 5-ish millimeters is always it's a rough estimate. But remember, you just don't want to, and when you're doing the sharp dissection, if you do it in keratinized tissue, you're not going to really see you're not going to see what you normally see when you're doing it in the mucosal tissues, on the internal of the flap. And just for reference, you never do a periosteal release incision on the outside of the flap. You're always doing it on the internal side of the flap. Just want to clarify that. If you were to accidentally cut off the keratinized tissue, which it's happened, where you poke through, stop. Don't do any more of that. Move deeper. Don't just keep cutting away. It can happen where you accidentally poke through the tissue. That means you're too high up and you got to go lower. Then when you're going lower, remember, you're just lightly cutting the periosteal layer. You're not stabbing deep into that tissue. If you do, then you're going to poke through anywhere you go through, really. At that point, you're going to start hitting some painful anatomy. You just want a light, like almost like a scrape of that internal, that periosteum tissue, so that the rest of it is done with a blunt instrument and you're not actually cutting anything anymore. That's why you do the blunt dissection beyond the sharp dissection, not just so you don't cut as much muscle tissue, but also so you don't start jamming into random anatomy with sharp instruments. So we're going to continue this video so you can watch it happen on a pig jaw. So again, me showing the mucogingival junction, showing why I'm going deeper than that line on a pig jaw. And again, this is why it's nice to do it on a pig jaw, to get a feel for that periosteum cutting and a visual. You can see this line form on the internal of the flap. And if you're looking, again, the bottom layer that's like deeper, it's a little bit pushed off the bone, but if you go even further, it's still attached. And here towards the right of the image, I'm starting to run into muscle tissue. And sometimes on muscle tissue, you have to make sure that you've cleared the periosteum and you have to go a little bit more into the muscle. So it is possible sometimes you got to use a little bit more of that sharp dissection when it's muscle or heavily scarred tissue, which sometimes there is when you're doing these on patients who have had a history of trauma or surgical trauma or a very badly infected tooth. Sometimes it's hard to see a clean layer of periosteum in those type of scenarios. And so sometimes you might have to extend the sharp dissection more, or you can start pulling the flap to see if there's been a clear separation that you can now bluntly dissect. So remember, on infected sites, that periosteal layer is going to be damaged a little bit already. So you just want to make sure that you're clarifying that you have kind of delineated where you can start doing your blunt dissection. And here you can see as we're doing the blunt dissection, I'm pulling the flap. Just ever so lightly pulling the flap as I'm taking my periosteum and just opening it up. No more sharp dissections happening, but notice how I'm getting into the muscle tissue and it's fighting back just a little bit. That's when sometimes you have to grab the blade again and start making that sharp dissection to extend the flap even further. But here, as I'm doing it, the facial flap is starting to significantly move. And I'm showing again right here, I'm just using a blade to lightly feather into the muscle tissue that's more to the right of the flap so that I can extend. And I'm showing now, once you've done some of that blunt dissection, you can grab your flap and start pulling it over the ridge to see how much mobility did you really get. Do you need more? Do you want more? If you're pulling it over the neighboring teeth, if you're pulling it over the ridge and touching the lingual flap, no problem. You've got a pretty good release that you can start sticking biomaterials into that region and have no worries that you're going to over-pressurize the tissue as you close things up. So you can add a lot of material and still get primary closure. And often, I'll tell you, you're doing these in scenarios where you want primary closure. And if based off those past principles, you don't always need primary closure, but if it's a scenario that you're worried that you need a lot of bone regeneration, or it's a severely collapsed ridge or severely damaged buccal wall, and often I'll do these in scenarios where like I'm doing like it's a immediate molar and there's no facial plate and I'm staring at half my implant. I don't want to like leave the top of the socket open in these scenarios. I want to get primary closure so I get as much bone regeneration around the implant as possible. So in these scenarios, yeah, I'm checking to make sure that I can get good closure, even though I'm adding a lot of biomaterials to the site. So that's the extent of it for doing that periosteal release incision. And again, the very first time you ever do it, my recommendation is indeed on a pig jaw. Now, if it's going to be a case that you do on a patient, my primary recommendation in those moments is to do it on a case you really don't need it. Try it first there. Like, you'll still benefit the bone grafting scenario by doing it. Yes, this is the downside. You end up moving the mucogingival junction, so you shorten the vestibule when you do this. Basically, by stretching the gum tissue closed, you're kind of losing some potential keratinized tissue growth that happens when you leave it open. But again, you're doing this in scenarios where you need every ounce of bone, and you are planning to manage the soft tissue later, whether that's a gum tissue graft or leaving it open when you do when you go for your second stage procedure and leaving the gum tissues just with some secondary intention to fill in with keratinized tissue. That in those instances, you're managing soft tissue later because you need bone first. And again, if you're doing it in the very first time on a human being, do it in a scenario that you might not need to do it. And maybe you don't have to, and this is the thing, the amount of blood dissection you do is going to correlate to how much advancement you get. So maybe on the first time you do it, just focus on cutting the periosteum very thinly and do very minimal blunt dissection. Again, the more blunt and the deeper you get into the tissues, that's going to equal more discomfort and more swelling afterwards. So if you're worried about patient discomfort, don't just want to try for remember, you're still benefiting their bone regeneration, and it's going to get you to in a scenario where you maybe do need to do more of this to be more skilled at it at that point. And so if you're trying it for the first time on a patient, do less extent of it, and you're not going to cause as much discomfort, and you'll get a good practice run at doing it. Now, if you're like, hey, I really want to practice this next to someone teaching me, watching me, make sure I'm doing it right, I teach this course, and I teach this procedure in St. Pete, Florida, myself with my partner, Dr. Vanessa Watts. We do this procedure probably twice. We do the procedure a lot, but we teach the course twice a year. So if you follow me on Instagram, Perio Hero, I'll post about it, but there are a lot of good courses that are pig jaw oriented. Dr. Rodrigo Nieva, essentially kind of almost invented the technique of using that periosteum to tack sutures. He does a great course on doing this technique. But most people teaching pig jaw courses on grafting techniques will show this technique on the pig jaw because it's such a useful simulant for it. So I'd say look anywhere for that. But if you want me to be right there with you, just look on my Instagram, Perio Hero, or Dental Show and Tell with an N, not an and. And we'll be posting about our courses in St. Pete, Florida, where we sit right there with you and teach you this technique. I don't want to jump into the suturing. I'm going to keep this episode short, and we'll go into the suturing tacking technique in another episode. Again, if you guys have any questions further beyond this, about this technique, about you doing the periosteal, hit me up. Hit me up on Instagram, Perio Hero. Ask comments on the Spotify, the app, whatever comment. And we'll try to get back to you with the answers to these questions. I think I'm a little better than Dr. Velo about getting back to you guys. You don't have to, trust me guys, it helps when you guys subscribe and comment. It does mean a lot to us. I do read them, and it keeps me going and wanting to do more and teach more. So if you got questions, I think it's helpful for not only yourself, but also for the community. So remember, share, comment, all the things above. Tell your moms and grandmas about the Periosteal Release incision and come here and learn more about it, guys. Thank you very much. Till next time, Sasha out.